Good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on chronic obstructive pulmonary diseases. I'm Aditya, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker, Dr. Sohail Mohammed. Dr. Sohail Mohammed is an accomplished respiratory medicine specialist and academician, currently serving as assistant professor at Al Amin Medical College, located at Vijaypur. A university rank holder in MD Respiratory Medicine from RGUHS. He has also earned top honors, including first prize in the 34th Purview quiz conducted by CREST. He previously served as assistant professor at Kanachur Institute of Medical Sciences, Mangalore, and is an active contributor to medical education as a CME speaker and postgraduate presentation moderator. Dr. Sohail works reflect a strong commitment to teaching, research, and advancing respiratory healthcare. Over to you, Dr. Sohail.
Yeah, hi. Thank you, Aditya, for the warm welcome. I hope my screen is visible and my audio is clear without any disturbance.
Sir, your screen
Yes, doctor.
Yes.
Yeah, I'll share the screen now. And I request all the participants to mute their mic for a better webinar. Okay. Can you see my screen?
Yes, doctor, yes.
Yeah, okay. So hi, good evening, everybody. So I'm going to start the live webinar on the COPD, the chronic obstructive pulmonary disease. And myself, Dr. Sohail Mohammed, I'm a consultant pulmonologist. So before we begin, I want to challenge all of you regarding some myths about the COPD. Okay. So let us see one by one. Is COPD reversible or irreversible? Is it reversible or irreversible? Okay. Is it progressive or its progression can be slowed down? Okay. Right. So if you are saying slowed down, then can smoking cessation slow disease progression? And why we are seeing COPD increasingly common among women? Sure. Last but least, is pharmacological therapy alone sufficient to manage COPD? I mean to say only the medication part is sufficient to manage COPD. Okay, so these are some myths. So don't worry if you guys are confused or don't know. By the end of this webinar, you will be able to answer all these with confidence. Okay. So let us begin our webinar. So what is COPD? It is a chronic lung disease which is characterized by persistent, okay, it is persistent respiratory symptoms and airflow limitation, which may be due to airway as well as alveolar abnormality. And it is significantly caused by exposure to harmful particles or gases. So this is just a simple definition. It's a persistent respiratory symptoms with airflow limitation. And it is due to exposure to harmful particles or gases. So key characteristics of this disease are chronic. Of course, it is a chronic disease. This can be preventable and treatable. It causes persistent airflow limitation. But why does the COPD matters? Because it causes public health burden and it leads to disability as well as mortality. That's why we have to think and worry about the COPD. Before going to the actual COPD part, let us know the burden. When you see the global impact, it's a leading chronic lung disease and one of the top cause of death and disability. Whereas in lower and middle income countries, as well as in India, most of the death is because of COPD. And as we all know, the indoor pollution, the biomass fuel exposure risk is also very higher side. When we compare it to the healthcare burden, frequent exacerbations can cause burden to the healthcare facility, as well as it also leads to high healthcare cost and reduced productivity as well as quality of life. So overall, COPD is a common, preventable, often underdiagnosed and a major cause of long-term morbidity and mortality. We all know about the diabetes because of the awareness, because of the extensive screening program, because of the long-term complications of the diabetes. We all know what actually diabetes is. But the COPD, which is also a chronic disease, which also causes a very big impact on public health burden, we often underdiagnose it because of the underscreening or lack of screening strategies. So when we see side by side, the risk factors for COPD include smoking, indoor pollution like biomass fuel exposure, outdoor pollution like air pollution or occupational dust. Whereas on diabetes, it is obesity, sedentary lifestyle, and genetic predisposition. Detection, often the COPD is underdiagnosed, and when you go for diabetes, it is routinely screened. Whereas the stage at which the COPD diagnosis is frequently very late, because of that significant lung damage has already present. The stage of diagnosis in diabetes has improved now because of the screening timely intervention. But when you see the public health focus, yes, the COPD has lower awareness and limited screening program as compared to that of the diabetes. So I'm not comparing it with the diabetes. I'm just showing you the data regarding the comparison. So COPD also adds to the global burden, but it remains less frequently screened and often diagnosed late. Before going to the clinical features part, let us know how the COPD come across the life course. So it's not always the smoking or pollution or the harmful particle exposure which causes COPD. The early life factor, which includes the poor lung growth due to some congenital anomalies or childhood recurrent respiratory infections, prematurity or low birth weight, biomass exposure or air pollution in the early childhood. So that all causes a lower peak of lung function. So these individuals will never attain the optimum peak of lung function in their adult life. When the adult life is attained, the smoking, occupational dust, as well as indoor and outdoor pollution will cause accelerated lung function decline. And in absence of these two, even at the normal age-related lung decline, there will be reduced physiological reserve. So, reduced lung growth, adult exposure, both together can cause severe and early COPD. So, the take-home message from this slide is it's a life course disease, and not all the patients they start in the adulthood who are having normal lung function, and it can result from an impaired lung development as well as accelerated decline or both, which happens during the life course. So this I want to clarify everybody. So as you all know, there are certain etiology as well as risk factors. Among them, the first is environmental exposure, which is a tobacco smoke, both active as well as passive, and indoor pollution, that is biomass fuel exposure, that wood, dung or coal. Occupational exposures like dusts, fumes, chemicals. Also, there are certain host and developmental factor. With increasing age, there is a decline in lung function. Alpha-1 antitrypsin deficiency, important genetic susceptibility causing COPD. Airway hyperreactivity as well as poor lung growth in childhood. Prior respiratory insults also contribute to COPD, which includes recurrent childhood respiratory infections due to lack of vaccination or improper hygiene, pulmonary tuberculosis, which is of course another common infective disease in our country, and HIV associated lung diseases. Other chronic airway diseases like long-standing asthma as well as asthma and COPD overlap. They can also lead to COPD because of the fixed airway obstruction due to recurrent inflammation. So routinely ask about the biomass fuel exposure in all the patients with chronic respiratory symptoms, especially the female gender, the women who are having COPD. And COPD is not only a smoker's disease, especially in a lower and middle income countries. In case of early onset COPD, non-smoker or those who are having family history, always screen for alpha-1 antitrypsin deficiency. When we see the clinical features, we all know dyspnea, that is the breathlessness, which is initially only on exertion, but later it may progress to rest because it is a progressive disease. Chronic cough, which is occurring often daily, and sputum production, and this sputum production is not purulent or it is not serous, it is often mucoid. Wheeze or chest tightness can be seen because of the bronchoconstriction. Fatigue and reduced exercise tolerance because of the decline in lung function. These are the symptoms when the patient is having a stable COPD. When the patient is having exacerbation of COPD, there will be sudden worsening of breathlessness, cough which has increased, and the sputum volume has increased, as well as the consistency changes to purulent if there is an infective cause. And the change in color of the sputum signifies us the bacterial infection, and such patients may require hospitalization. When the disease advances, we can see there will be weight loss and muscle wasting because of the chronic inflammation and the systemic release of inflammatory mediators. And when the patient starts developing hypercapnia, he may develop having morning headaches. Because of the right heart strain, the right heart dilatation, cor pulmonale, the patient may develop peripheral edema, and the patient may have structural lung disease leading to frequent infections. So clinical clues are chronic and slowly progressive symptoms, which can often worsen in the morning in few patients, and there is history of recurrent chest infections. So when we come across how to take the history in a COPD patients, because taking history in a clinical practice is an art. If you are expert in this art, your 90% of the work is done. You don't have to rely on any investigation much. You can just ask the investigation to confirm the diagnosis. So how to take history in a COPD patient? So first, you have to assess the symptom. You have to start what symptom the patient has presented to the OPD, and the symptoms most commonly are breathlessness, which is progressive in nature. And how do you assess the severity as well as the progression is depending on the grading. If the patient tells MMRC dyspnea scale he was having during exertion and now it has gone at rest, then it is a clear-cut sign of progression. And patient who is having chronic cough, sputum production, wheeze or chest tightness, and very important is to assess the allergic history. Allergic rhinitis, sinusitis, conjunctivitis, dermatitis. So allergic history will help you the concomitant diagnosis of bronchial asthma, because the treatment aspect is little different when you see a asthma and COPD overlap with a plain COPD, which we'll come and discuss in the subsequent slides. Exposure history is very important to have a retrospective clue for etiology as well as risk factor, among which the smoking history. You have to ask whether it is BD smoking or cigarette smoking, and what is the duration, how many cigarettes per day, and how many years. There are certain pack years or smoking index which are available in different references. Very important is biomass fuel exposure. Again, to which biomass fuel they are exposed, to how many hours they are exposed in a day, and to how many years of exposure, because that signifies the impact. Occupational history, very good. We have to ask about the occupational history, and during the occupational history, you have to ask the other co-workers are also having similar symptoms. And regarding the indoor and outdoor air pollution. When we ask about the exacerbation and treatment history, it gives you the idea about how well controlled their COPD is. And you can assess the rate of their lung function decline, because the number of exacerbation increases, their decline in lung function will be on higher side. And the hospital admission, you have to take a proper history, whether it is on in ward or it was in ICU and patient was started on NIV or with the oxygen support. Very important history in the treatment aspect is which inhaler they are using and whether they are adherent to the inhaler, because very many patients, they use inhaler SOS basis only during the exacerbation or when there is symptom. So you have to have the adherence history, as well as the very important aspect which I see in my clinical practice is the technique. Even though you prescribe correct inhaler to a correct patient with a correct dosage, if the technique is wrong, it is of no use. So technique is very important equally as you take the history of symptom and exposure. And you have to ask the prevention response to bronchodilator, and vaccination history is also required. Past history, which is important, the history of pulmonary tuberculosis, because that can also contribute to COPD and accelerate the lung function decline, or recurrent other respiratory tract infections. Comorbidities also play an important role, because if you have a COPD patient and you are treating him with an optimum medication of COPD, but still he is having recurrent exacerbation, then you have to think of comorbidities, because comorbidities itself are the cause for acute exacerbation of COPD. Among them, the severe comorbidities include cardiovascular diseases, diabetes, obstructive sleep apnea, gastroesophageal reflux disease. So those symptoms can be weight loss, hemoptysis, chest pain, or you can take family history of lung disease, and early onset, which I already mentioned, non-smoker COPD, you have to consider congenital alpha-1 antitrypsin deficiency. When I told about the MMRC grading, all of you might be knowing the Modified Medical Research Council grading. It starts from grade 0 to grade 4. Grade 0 states the breathlessness is only with a strenuous exercise. Grade 1 tells when the person hurries on the level ground or walking up a slight hill. Grade 2 tells the patient when walks with the similar people of same age on the level, they will have breathlessness or stops walking at the own pace after some time. And in grade 3, he stops after 100 meter and sits to take breath, or after certain seconds or minutes. And grade 4 is too breathless to leave the house or to do basic activities, dressing or undressing. So this is how you grade the breathlessness, and this is how you assess the progression, whether it is going from 0 to 2 or 1 to 3 or 0 to 4. So this grading is very important. So what can be the physical findings, examination findings on COPD? So when you see a full-fledged COPD, the chest appears barrel-shaped chest, where the anterior-posterior diameter is almost equivalent to transverse diameter. And in exacerbation, patient may have use of accessory muscles of respiration, which are neck muscles prominent. They may have pursed lip breathing, and in emergency department, the patient may be found sitting in the tripod position, which helps them to ease their breathing difficulty. And if the patient has concomitant comorbidities, the patient may develop cachexia and weight loss. Pertaining to the respiratory department or respiratory system, the examination findings include on percussion, if it is a full-fledged emphysema, there will be hyperresonant node because of the presence of trapped air. Breath sounds are reduced and expiratory phase is prolonged with a diffuse expiratory wheeze. And in exacerbation state, there will be paradoxical inward movement of the lower ribs because of the over sign. So that is what we are going to see in the exacerbation. When do we see clubbing in COPD? Ideally, the clubbing is not typical in COPD. So clubbing is not typically seen in COPD, but when you see a COPD patient with the clubbing, you have to think of associated conditions like bronchiectasis and take history pertaining to bronchiectasis, lung malignancy, because both share a common etiological risk factor, that is smoking, lung abscess and empyema, because of the recurrent chances of infection, they may have higher tendency to develop these. So when you see clubbing in a COPD patient, you always think of associated condition, because plain clear-cut COPD will not have clubbing. When you see raised jugular venous pressure, peripheral edema on cardiac examination, loud P2 and right ventricle heave, all these are suggesting a favor of core pulmonale or pulmonary hypertension. So always, along with the respiratory system examination, you should do a cardiovascular examination in an acute exacerbation patient as well as in stable COPD patient. So examination pearls, physical signs may be subtle in early COPD, but don't think that normal examination finding exclude the COPD. So how to go ahead with the diagnostic evaluation in the COPD? The spirometry is considered to be as a cornerstone of the treatment. So what do we see in the spirometry? It is required to confirm the diagnosis and the post-bronchodilator. There are two tests, pre-bronchodilator before giving the bronchodilators. After doing the test, we have to give a bronchodilator challenge and then perform the test again. And post-bronchodilator ratio of forced expiratory volume in 1 second to forced vital capacity is seen. If it is found to be less than 0.7, it confirms a persistent airflow limitation. And it helps in grading also, which I'll tell you in the next slide, which helps you to assess the severity. And it is very important, is performed in a stable state. So when a patient is in emergency department in acute exacerbation, don't ask for spirometry, because the patient needs to be stable. It is an effort dependent, it needs coordination. So patient needs to be stable and conscious and alert. Chest X-ray findings, yes, there are few chest X-ray findings which are very, very classical for a typical COPD. Hypertranslucent lung field because of the excessive air trapping. Diaphragms are flattened because of the, again, air trapping. Ribs are straightened. Intercostal space are widened. Vertical cardiac silhouette, we call it as tubular heart. Hilar can be prominent in case of pulmonary hypertension, and because of persistent air trapping, the patient may have bulle. I just want to ask everybody, like CT scan, the CT thorax is routinely asked in COPD, yes or no? Do we ask CT thorax routinely in a COPD patient? Yes or no? No. Very good. Most of you are telling no. Very good. So what makes you ask a CT thorax in a COPD patient? What do you want that indication, like not indication? What are the things which will make you to ask a CT thorax in a COPD patient? Can anybody answer? Lung cancer, very good. Tumor, very good. Good. If you have any red flag sign which are suggesting of malignancy, because both are having a common sharing risk factor, very good. Comorbidities. What comorbidities? Yes, lung malignancy is one, definitely. CVD. You mean bronchiectasis? Yes, definitely. Bronchiectasis, very good. Bronchiectasis, ILD, yes. ILD also, bronchiectasis also. Sepsis, no. Chest injury will come into different entity. And sepsis, we don't need CT to diagnose sepsis. ILD, agreed. Bronchiectasis, agreed. Again, they have a common sharing risk factor. Tuberculosis, okay, not always we do, because in chest X-ray we get the findings. Any vascular cause? Any vascular? A patient has come, COPD patient, severe breathlessness, pulmonary edema. Okay, severe breathlessness. Okay, I'll give you a clue. Pulmonary hypertension. Do we need a CT for pulmonary hypertension? I'll come to that. Definitely, pulmonary hypertension has to be ruled out, but yes, pulmonary embolism. So that is the correct answer. So when you see suspected bronchiectasis and to see the emphysema pattern, the suspected lung malignancy, suspected pulmonary embolism, okay, as well as symptoms out of proportion to severity on spirometry, and sometimes as a prerequisite to surgical procedure, pre-surgical or lung volume reduction assessment. Okay, so these are the certain indications which are common. Okay, there are many, but these are common. And when do we ask for ABG? In severe disease and when we are suspecting hypercapnia or during exacerbation to rule out hypercapnia. And what ABG shows is hypoxemia, of course, and in advanced disease, we can see hypercapnia. And somebody has told pulmonary hypertension. Yes, to assess pulmonary hypertension, we need to get a 2D echo, which evaluate right ventricle function, and it is indicated in peripheral edema, disproportionate dyspnea, or when there are features of core pulmonary. So this is a real X-ray. You can see the findings. This is a finding. What all findings can you see? Can anybody tell me what all findings, which I have told already? What all the findings you can see in this X-ray? Yes, tubular heart. Vertical silhouette, that is straightening of ribs. Yes. Okay. Straight ribs. Okay. So what are the classical signs of hyperinflation? So hypertranslucency is seen, flattening of diaphragm, straightening of ribs, intercostal space are widened when the ribs are straightened. Hilar prominence is not seen in this. Yes, some part we can see hilar prominence. Yes, and then what we can see is peripheral pruning of vessels. Cardiac silhouette is vertical and narrow, and bullae are not there in this. Bullae can be present, may or may not be. Okay, but these are the signs of hyperinflation. Okay. So can anybody tell me what are the findings on this CT? Have you seen the CT of a COPD patient? No. Can anybody guess what are the findings? How does this emphysema looks? Okay, can anybody tell me what are the classification of emphysema? How many types of emphysema you know? How many types? Basic question. Centriacinar, very good. Two more. Panacinar, very good. Centriacinar, Panacinar. One more and we'll go ahead. Which is around the septa. See, you don't have to stress so much on your brain. It's just a self-explanatory. Centri means center, centri, acina. Acina means airway. And para means around, just adjacent. Okay, septa, paraseptal. And pan means everything. Okay. So here, so the red arrow shows centri-acinar. The red arrow shows centri-acinar emphysema. So you can see these round spaces here, which are black. Here appears black on CT. So you can see these black shadows here also, which is the red arrow is marking. Okay. And these are paraseptal, which is around the septa. Can you see? Now you will not forget the CT. Small air spaces around the septum. Okay. So the red one is centriacinar and the green one is paraseptal. And the one more panacinar. Can anybody tell me where do you see panacinar? Panacinar is a typical of which disease? Which disease typically causes panacinar emphysema? Yes, which I mentioned alpha-1 antitrypsin. Alpha-1 antitrypsin deficiency, there's one of the congenital cause, more likely to cause panacinar emphysema. Okay. So what are the possible complications with paraseptal emphysema? So this is a paraseptal emphysema, right? What can be the possible complication? If you see this CT and the patient has gone and patient has come for a emergency department with severe breathlessness. So what are the possible complications? Bulla will cause sudden breathlessness. Failure, respiratory failure. Okay, that is one of the possibility, but I'm asking pertaining to paraseptal emphysema. Empyema. Yeah, something related to pleura. Yes, rupture leads to pneumothorax. Okay, so these patients are prone to develop pneumothorax. Okay, because of the paraseptal location, they rupture and give rise to pneumothorax. Okay. So the one thing which I have already told is classification or grading the severity of airflow obstruction. So we divide into mild, moderate, severe, and very severe. First, you have to see the post bronchodilator FEV1 upon FVC ratio, which is less than 0.7. Then we'll go to the mild, moderate, severe, very severe. So FEV1 of more than 80% is mild, and less than 30% is very severe. In between that is moderate and severe. So this is how we classify based on spirometry FEV1. So these are certain ECG changes which has to be seen in a COPD patient. The important is P pulmonale, which is a tall P wave more than 2.5 mm. And it is seen in lead 2, 3 and AVF, which is suggestive of right atrial enlargement. And you have to ask for assessment of pulmonary hypertension. Along with that, right axis deviation, again, right ventricle strain, low voltage QRS complex because of the tubular heart, the hyperinflated lungs, the voltage are low. Poor R wave progression, again, they are caused by hyperinflation and altered heart position. Right ventricle hypertrophy, where there is a R wave is dominant in V1 and RS ratio is more than 1. Arrhythmias are common because of the hypoxemia, where we have atrial fibrillation, multifocal atrial tachycardia. They are common during the exacerbation or post-exacerbation state. So any chronic COPD patient, ECG, don't just look for myocardial infarction. You always look for any other right heart changes. So P pulmonale, right axis deviation, always make you think of pulmonary hypertension. When we come to the management part, management of COPD has two important aspects, the non-pharmacological and the pharmacological, because both are equally effective for treating COPD. You just can't give alone non-pharmacological or pharmacological. Both has to be given in an optimum way. Smoking cessation, if the patient is a smoker, very important, most effective intervention to slow down the disease progression, which I have asked you in the before. Yes, smoking cessation helps you slow down the disease progression. It will not halt or reverses the COPD. It will not stop progression. It will not reverses. It will just slow down. For example, if it is running very fast, the smoking cessation can make it slow. So it benefits in all stages of COPD, and it can be done through counseling as well as pharmacotherapy, and also active. Along with that, passive smoking should be stopped. Environmental exposure, main important is biomass. So you have to improve the household ventilation, ask the patient to improve household ventilation, reduce occupational dust and fumes, wherever it is possible, and you have to reduce indoor and outdoor pollution. See, when it starts from us, the effect will be seen overall. We cannot just complain there is increasing air pollution or indoor or outdoor. It has to be start from within. Then the effect can be seen. Vaccination, definitely the patient needs to be vaccinated because they are at higher risk of developing recurrent respiratory tract infections. Rehabilitations, which is recommended for all the symptomatic COPD patients, which needs training. Training is not vigorous training. It can be limb exercise, simple limb exercise, pursed lip breathing. Ask the patient to inhale through the nose, and then to the pursed lip, they have to exhale as much as possible. Okay, it has to be done. That is pursed lip breathing, and patient education regarding the disease and the chronicity. Patients who are having chronic hypoxemia, where PaO2 is less than 60 millimeter mercury and saturation at rest is less than 88, long-term oxygen therapy, 1 to 2 liter can be given for more than 15 hours per day. It helps in improving the outcome. The other effects of hypoxemia are not seen if the oxygen therapy is given at a time and for a particular period of duration. Nutritional and physical activity, patient may have weight loss and muscle wasting. So you have to improve the nutrition as well as physical activity to prevent these things. So non-pharmacological therapy is the foundation of COPD patient, and medications are an add-on. Okay, without non-pharmacological therapy, there is no point of giving only medication. You have to take a proper assessment of non-pharmacological measures, and you have to address them to the patient so that they should be aware of these things along with the medications. So these are certain vaccinations. Why it is helpful? Because it helps in reducing the exacerbation, it helps in preventing severe respiratory infections, and it reduces the hospitalization and mortality. So these are the list of vaccination which needs, the details of which are given in respective guidelines. So before going to pharmacological treatment, this classification should be known. There are three groups, group A, B, E. And these three are divided depending on the number of exacerbations and which leads to hospitalization and their symptom control. The grading which I had told MMRC is less than 1. It belongs to group A with 0 exacerbation or 1 exacerbation not leading to hospitalization. The people who are having grading MMRC more than or equal to 2 with 0 or 1 exacerbation but not leading to hospitalization belongs to group B. So these two are in the early. Group E are the late stage or severe diseases where patient will have, irrespective of any breathlessness, if they have more than or equal to 2 exacerbations and among which one is leading to hospitalization, whether it is a ward or a ICU or with NIV, they belong to group E. So our patients, majority of them will fall to group E because of the late diagnosis and under screening. So principle of drug therapy, the first important is to reduce the symptom and prevent exacerbation. So please keep these two things in mind. You just don't have to reduce the symptom. You have to prevent further exacerbations. So the inhaler is based on the symptom burden. Group A and B, we can start with dual inhaler therapy or a single inhaler therapy. And if they are belonging to group E, the triple therapy can be added. But very important is correct inhaler technique, which is very, very crucial. So group A, low symptom risk, single bronchodilator can be added either in the form of beta-2 agonist or muscarinic antagonist. Group B, again, the dual bronchodilation is must. In group E, the triple therapy is preferred, but ICS has to be chosen very carefully in COPD. Okay. So what are the few indications where we have to prescribe ICS in a COPD patient? If the patient is having frequent exacerbations, that is belonging to group E, or patient has a high eosinophil count with an asthma and COPD concomitant overlap. So in these patients, inhaled corticosteroids can be added to beta-2 agonist as well as muscarinic antagonist. Otherwise, please always treat COPD patient, stable COPD patient with a dual or a single bronchodilation, preferably dual long-acting beta-2 plus long-acting muscarinic antagonist. So those are the cornerstone. ICS is reserved in selected patients. Okay. So coming to the inhaler technique, though I told you inhaler technique, it sounds very simple, but it is very important step in management of COPD. I have seen many patients with the various types of inhaler, the names of which also they don't know, but they don't know how to use. Okay, they will be knowing how it works, but the methods, the proper method, the coordination, they don't even know about it. So you have to reinstate that every visit, every follow-up. You have to take a inhaler technique review method. You ask them to do and show to you. Just don't ask them to list out the steps. Ask them to do it in front of you. Take 2 minutes, spend 2 minutes time with the patient and see how they are inhaling with the inhaler. Just don't write and send them off. Okay. So when we see the meter dose inhaler, where it will be incorporated with the inhaler pump. So before removing the cap, you have to shake and ask the patient to sit relaxed and exhale fully. Then you have to keep the inhaler in the mouth and there should be a airtight seal. And the moment the patient press, the patient has to start inhaling. Okay, so the coordination is very important. And once they take a deep breath, remove the inhaler and hold the breath for few seconds, at least 5 to 6 seconds, then exhale. So this is how the inhaler, the meter dose inhaler is taken. And after that, ask the patient to rinse the mouth and gargle, throat gargling, especially if the inhaler contains an inhaled corticosteroid. Coming to dry powder inhaler, which is Rotacap, that will come with a device. Okay, so the capsule is inserted in the device. Okay, and then either in the form of pressing or rotation, ask the patient to sit and exhale, keep it airtight, then take deep breath. After that, you have to remove the device and hold the breath for 5 to 6 seconds. Again, the same steps. The difference is there, we need a coordination. Moment the patient presses, take the deep breath. Here, the moment the patient initiate the breath, the drug will start getting deposited to the lung. So this does not require coordination, but they need a proper inspiratory effort. If there is a very elderly patient there we can add a spacer. Okay, it's a tubular structure where at the one end you have to attach a meter dose inhaler and the other end is kept in the mouth. Ask the patient to press, the drug will be released into that tubular device, and ask the patient to take 2-3 deep breath, inhale, exhale, inhale, exhale. So it has a single way valve which will not allow the exhaled air to enter into the tubular device. So in that way, the patient can take. So these are certain inhaler technique which are available in the YouTube in the form of videos. So you can search the name and see that. And please make sure every visit of the COPD patient, the inhaler technique is reviewed. Okay. And if there is any mistake, correct it and send them back, because this is one of the cause for exacerbation in COPD. So acute exacerbation of COPD, by definition, it is worsening of respiratory symptoms. Okay. And it requires a change in treatment. So common triggers are viral infections followed by bacterial, yes, pollutions, poor inhaler adherence or incorrect technique, comorbidities like heart failure or pulmonary embolism, and sometimes there won't be any cause. So there the dyspnea has increased, cough has increased, sputum has become purulent and increase in volume, and additional symptoms like wheeze and chest tightness has been introduced. So management remains the same. In this, short-acting bronchodilators can be given in the form of nebulization or the meter dose inhaler with the spacer, and we can give repeated dose till the patient becomes symptomatically better. Corticosteroids, yes, short term we can give for a short period of time. It helps in faster recovery, but it has its own risks too. Antibiotics is indicated when the patient is having purulent sputum or increased dyspnea and severe exacerbation which requires ventilation. Oxygen therapy, if the patient is hypoxemic, please remember, don't give him full-fledged oxygen. When a patient has come to emergency department and you know the patient is COPD, or by understanding the history, examination, you came to diagnose it is a COPD, don't give very high flow oxygen. Maintain a targeted oxygen therapy of 1 to 2 liter or with a Venturi mask of 24 to 28%, and the saturation should be between 88 to 92. Don't try to maintain it 9900. The tendency we have, whenever any hypoxic patient comes, we try to make him hit the century. No, for COPD patients, 88 to 92 is enough, because they already have lost the carbon dioxide drive. They will be hypercapnic. The hypoxic drive is keeping the ventilation going on. If you correct the hypoxia, you are going to blunt that hypoxic drive. So most exacerbations are infection related. Purulent sputum helps in guiding the antibiotic, and NIV helps in hypercapnic patients who are conscious and oriented. So when they come for follow-up, what to assess? First is symptom control, take MMRC grading and how the symptoms are impacting on the daily activities, whether it has improved or worsened. Exacerbation history within last year or from last visit, how many exacerbation, whether they were self-limited or they were admitted to the ward or ICU. Review the inhaler technique, which is very important, and whether they are adherent to the treatment. And also you ask about the side effect. Risk assessment, yes, again for non-pharmacological, whether they have stopped smoking or biomass exposure, comorbidities have been addressed properly, oxygen requirement, if they are on, whether it is correct or not, and vaccination status. So escalation of the treatment from single, you can go to dual bronchodilator therapy. If they are having again eosinophilia or concomitant asthma or frequent exacerbation, then go to inhaled steroid. Other add-ons are roflumilast, which can be given in chronic bronchitis type, or vaccination, or sometimes we can add macrolide azithromycin for a short period of time. And de-escalation should be done when the patient is having a recurrent pneumonia or eosinophil count has come down and there is no history or frequent exacerbations. So you can de-escalate to only dual bronchodilator therapy. So follow-up is very continuous and it is dynamic. So when the patient comes to you, be happy that he is having a good symptom control, but don't neglect. It's a dynamic and a continuous process, and the disease is progressive. It won't stop there unless and until you keep it maintained. So always take inhaler technique and escalate the therapy or de-escalate the therapy accordingly. So what common mistakes we do in COPD management is we diagnose the COPD without spirometry, which is not correct. Yes, if the symptoms are very much going in favor of COPD, you can wait and do the spirometry when the patient is stable. And overuse or inappropriate use of inhaled corticosteroid, which is having their own adverse effect. ignoring the inhaler technique and adherence, which is very important mistake. And we always treat the symptoms. And once the symptoms subside, yes, go aram se, don't do anything. No, you have to prevent further exacerbations. And when all these are okay, tick mark, treat the comorbidities. Still patient is having symptoms, treat the comorbidities. So take home message is most of these failure are due to correctable management error and not lack of medications. What are the comorbidities which can be suspected in a COPD patient? So when we go for a respiratory cluster, pulmonary hypertension, bronchiectasis, lung malignancy, there can be overlap with asthma or interstitial lung disease. In a cardiovascular, we can have systemic hypertension, ischemic heart diseases, arrhythmias, and heart failure. Whereas in metabolic, they have obesity, metabolic diabetes mellitus, or gastroesophageal reflux disease. Whereas in neurocognitive, because of the elderly age and due to chronic disease, they may develop depression, anxiety, or cognitive impairment, which also hamper the inhaler technique. So always choose your inhaler technique depending on your patient profile. And they may also have weight loss, osteoporosis, anemia, and renal dysfunction. So the comorbidities of the COPD can also independently worsen the prognosis. So they should be actively screened and managed. So when we see the difference of asthma, COPD, and heart failure, because not all the V's are asthma and not all the breathlessness are COPD. So age of onset, again, COPD is elderly and heart failure is also, yes, now it can occur in any age. And asthma is a childhood disease. Smoking is commonly seen in COPD, may or may not be in heart failure. The symptom pattern, it is persistent, slow, and progressive in COPD, whereas in dyspnea, heart failure, it is having postural variation like orthopnea and the nocturnal symptoms like paroxysmal nocturnal dyspnea. Asthma gives you a very marked reversibility on spirometry. They have a characteristic significant bronchodilator reversibility. And when you see the cardiac, the BNP as well as 2D echo, they are not normal in heart failure, but in advanced COPD patients, we can see pulmonary hypertension or cold pulmonary. Okay. So let us see a case. Are you all ready for a case? So the clinical scenario here, elderly lady came who is a known patient of COPD, but she also has concomitant asthma features like allergic history on exposure to dust and cold. Her symptoms exaggerate or aggravate. And she was on dual inhaler therapy, which is including long-acting beta-2 agonist and inhaled corticosteroid started from outside. But now she had a complaints of worsening dyspnea, which has progressed to grade 2 since 2 weeks. There was cough, and she has showed somewhere else and started on home nebulization with a long-acting beta-2 agonist and a inhaled corticosteroid combination. But there was no significant improvement. On presentation to us, she was conscious oriented, but her vitals were not looking normal. She had tachycardia, hypoxemia at room air, and BP was okay, but respiratory rate was on higher side. So in COPD patient, already on inhaled therapy, what you want to look for next when the dyspnea persists? First, you tell me whether the dual inhaler therapy which was given to her in the beginning was correct, because she has both COPD with asthma features. Okay, so let's go ahead. So on clinical examination, there was no pedal edema, but loud P2 on cardiac examination, and on respiratory system auscultation, there was few bronchi. So what does this loud P2 suggest in COPD patient, and what to do next? What step to be done next? Can anybody tell? Pulmonary hypertension. Good. So these are the investigations done. Chest X-ray was done, which showed marked hyperinflation without any other obvious pleuroparenchymal abnormality. Spirometry, which was not possible at present because she is in exacerbation, and at rest day she was having hypoxemia. 2D echocardiography was done immediately, which showed dilated right atrium and right ventricle with severe pulmonary artery hypertension. Blood test showing mild leukocytosis with the normal CRP and creatinine is normal. So our working diagnosis was acute worsening of COPD with underlying pulmonary hypertension, which belongs to group 3 of pulmonary hypertension, and she had a dyspnea out of proportion to airway obstruction. So she was initially managed with controlled oxygen therapy for a short duration of time and escalated to triple therapy in the form of nebulization because she was not able to take MDI with spacer also. Oral antibiotic was started in view of purulent sputum and exacerbation state, and for right heart strain, diuretics was initiated. After 3 days, she had a marked symptomatic improvement. Her vitals have improved, oxygenation at room air has improved, and pulse rate has come down. So what are the learning points? Persistent dyspnea and COPD is not always an airway disease. Always evaluate for pulmonary hypertension when symptoms are disproportionate. Loud P2 is a critical bedside clue. Escalation to triple therapy was effective in selected patients. And the fact that she was started on dual LABA as well as ICS for COPD and asthma was not according to the treatment part. Okay, she was supposed to be started with the triple therapy. So you have to treat the whole pathophysiology, not just the bronchospasm, and that helps you improving the outcome of the patient. So are you ready for some MCQs, and then we'll wind up the session. So which investigation is mandatory to confirm the diagnosis of COPD? Yes, so it's a post bronchodilator spirometry which showed, yes, FEV1 upon FVC less than 0.7. Which intervention is most effective in slowing down the progression of COPD? Smoking cessation. Very good. Okay. Here, 62-year-old woman with COPD, persistent dyspnea, no exacerbation last year, currently on long-acting beta-2 agonist. What is the best treatment? For this, you should know what group she belongs to. She has a grade 2 MMRC dyspnea, but no exacerbation. So she belongs to, yes, group B. So you have to go for dual bronchodilator therapy. COPD patient with frequent exacerbation on ICS, started on ICS. Which factor best predicts the benefit from ICS? It's the eosinophil count. Which of these ECG finding is not typical of COPD? You can see P pulmonale, we can see right axis deviation, low voltage QRS complex, and right ventricular hypertrophy is not the left ventricular hypertrophy is not the typical. COPD patients presented with the increased dyspnea and purulent sputum. Saturation is 85. What should be the oxygen target? 88 to 92. Very good. 60-year-old man COPD has a PaO2 of 58 at rest. What is the most appropriate intervention? He has a PaO2 of 58. Why you want to give only pulmonary rehabilitation? Yes, should be long-term oxygen therapy, right? He has a chronic hypoxemia. Helps in improving the outcome and quality of life. Rehabilitation is given for all the patients. Okay. COPD patient has dyspnea out of proportion to spirometric severity. What should be done? You should add a bronchodilator. Why do you want to add a steroid? Why do you want to repeat spirometry when already the severity is shown? We have to evaluate for comorbidities, right? It's out of proportion, no? Okay, which statement best reflects the life course concept of COPD? Whether it develops only due to smoking, or it is always due to accelerated decline, or reduced lung growth in early life can predispose to COPD, or it is reversible with the early treatment. Yes, reduced lung growth in early life can predispose to COPD. Very good. A patient with COPD, post-bronchodilator FEV1 upon FVC less than 0.7, FEV1 42. So which category the patient belongs to according to FEV1 grading? 42. Always remember 80-30. 80 above mild, less than 30 very severe. In between somewhere moderate or severe. So two options are ruled out. Belongs to severe COPD. Okay. So COPD is a common, preventable and treatable, but it remains underdiagnosed and misdiagnosed because many patients, they don't receive treatment, or if they receive, it will be an inappropriate treatment. So early and accurate diagnosis will help by reducing the major public health impact, because it helps in reducing the exacerbation, preventing the hospitalization and improving the quality of life and survival. It is not just a respiratory disease, it's a systemic disease because they have multiple comorbidities, and these comorbidities will also influence the symptom and prognosis. They can also be a cause of exacerbation, and they independent require recognition and treatment. So optimum COPD care is having accurate diagnosis, risk factor modification, pharmacological as well as non-pharmacological therapy, and follow-up and reassessment. So it doesn't just include diagnose and treat. No, you have to follow up and reassess. So coming back to myths versus fact, COPD is a reversible disease, largely irreversible, but can be treatable and modifiable symptom-wise. Always progress despite treatment. Yes, it is a progressive by nature, but early diagnosis and proper management can slow down the progression. Smoking quit can help once the COPD develops. Yes, it can help in slowing down the lung function decline, not stopping. It is mainly a disease of male smokers. No, it is also increasing in women because of the biomass fuel exposure and indoor air pollution and inadequate ventilation. Inhalers alone are sufficient to treat COPD? No, it requires a multidimensional approach, pharmacological, non-pharmacological, and management of comorbidities. So I hope your myths which were there in the beginning are clear now, crystal clear and very well understood. So take home message is COPD is not curable, but it's a preventable, treatable and manageable with right approach. So don't just diagnose and leave it. Follow up, make it habit to ask inhaler technique, adherence and other comorbidities check, so that the quality of life and the public health impact is improved. So treat the airflow limitation, but never forget the person who struggle to breathe, because COPD care goes beyond inhalers. It requires listening, reassessment and long-term partnership. Thank you very much. If there are any questions, the podium is open for discussion.
Thank you, doctor, for this valuable, informative session. Doctors, please send your questions in chat box. Dr. Sohail will answer all your questions. So you can write it in chat box. He will interact with you. So Dr. Twinkle Mystery is asking, is advanced COPD home BiPAP will help to prevent chronic hypoxemia? Are you there, Dr. Sohail?
Hi. Yeah.
Yes,
I
yes.
was not able to unmute. Okay.
Okay.
Yeah, Dr. Twinkle has asked advanced COPD home BiPAP. Home NIV indications are different. Yes, advanced COPD patients were having chronic hypoxemia with hypercapnia during exacerbation, and the hypercapnia has not controlled during the hospital stay. Yes, in those patients, it may help home NIV. Okay, so things can be helped, but there are certain indications for it.
Doctors, we are posting the certificate and feedback form link. So please fill the form to get your certificates, and
There is a
you will
question
get the certificates by
by
3 working
Ardeep
days.
Singh Solanki.
So,
Sildenafil helps in pulmonary hypertension with COPD. See, the pulmonary hypertension in COPD is secondary to hypoxemia, which belongs to group 3 of pulmonary hypertension. And all these pharmacological therapy in pulmonary artery hypertension is reserved for group 1, which is idiopathic pulmonary artery hypertension. So for the COPD associated pulmonary hypertension, normally we give mild diuretics and the correction of hypoxemia. We don't use any pharmacological therapy for pulmonary arterial hypertension because the cause is known here. Correct the hypoxemia, mild diuretics to relieve the right heart strain is enough. So are there any further questions?
doctors, I shared the certificate and feedback form link in the chat box itself. So kindly fill the form to get your certifications. It will be.
Also, I would like to ask the participants if they have any interesting topic which they want me to take in upcoming webinars. They can share in the comments. If it is feasible and possible, we can think of it. Okay, tuberculosis. Is oral or IV steroid and tab-like delivery will help in COPD? Sorry, Dr. Tinkle, I didn't get the question. Can you rewrite it?
Good evening, sir.
Yeah, good evening.
Sir, I'm working in the intensivist ICU. We see oftenly so many patients with acute infective exacerbation of COPD.
Okay.
Generally, initially we are settling with the NIV, but with severe CO2 retention, the IV steroid and the medicines like a Davry, it will help to early wash out the CO2 retention.
First of all, IV steroids are used only if there is a bronchospasm on examination. And if the bronchospasm is not subsiding, you can use IV steroid and also during exacerbation. But if there is a retention of carbon dioxide, then you have to use NIV more than any other medication. You can use NIV and you can apply some bi-level positive pressure, and that helps the patient for early washout of carbon dioxide. And ideally, hypercapnia and respiratory acidosis is one of the indication for non-invasive ventilation.
Dr. Twinkle is saying thank you, sir.
Thank you. Okay. Okay, so if there are no
So,
further question, we can wind
any
up.
further doubts, doctors, you can directly ask Dr. Sohail, or you can write it in the chat box.
I think there were no questions. I think we can wind up the day.
There is one more last question. We'll take that and we'll wind it up. Deriflin used in
Yeah.
COPD. Methylxanthines can be used, but what certain studies have suggested that deriflin may also have the risk of tachycardia, and during hypoxia there is already existing tachycardia. But there are certain cardio-safe methylxanthines, so yes, you can use it, and there has been practice that deriflin can be used. Okay, but be cautious. If it is possible to treat it with bronchodilators, inhaled or systemic steroids, prefer that. If it is not, we can add on methylxanthines. Besides spirometry, what is the best investigation to diagnose COPD? Besides spirometry, I don't think so. Spirometry is the investigation which is used to diagnose COPD as per guidelines, and beside that, there is no best investigation. You can take a history, risk factor, and to the max, you can get radiological investigation like chest X-ray or CT thorax, which may show hyperinflation as well as emphysema, respectively. Other than that, there is no best investigation.
Thank you, Dr. Sohail. I'm sharing you the certificate registration and webinar feedback form once again. So if you have missed it, kindly fill it. You will get your certificates within 3 working days.
No. Yeah. The certificate will be sent immediately to your inbox. Please do check in your spam or inbox.
Okay, so if there are no questions, we can wind up the session. Thank you everyone for the patient listening. And thank you Mediversal Academy for hosting this webinar. Thank you very much. Have a great weekend. Bye.
Thank you, doctor.
Thank you,
Thank
sir.
you for
Thank
the
you.
informative session. I thank you.
My chat box is not opening.
Sir, there will be an option beside participants naming chat. So you have to click that. It will open.
It's not opening. I am opening. Disappears.
Yeah, Dr. Mohit, I'm extremely sorry. Doctor has left the session. We will end the session here. Next session, you can ask your question.
Okay.
Sorry for the inconvenience.